I'd like to thank the speakers for sticking to time. Please don't go away because the actual discussion starts now. And Ronnie, I just have a quick word. It would be politically incorrect to compare Canada with India, actually, till about a month back. So I think you need to be a little careful.
I'll put Australia next time.
Yeah. So I think if you see the speakers, they have, with examples, nicely woven take-home messages. And I'm going to come back, re-emphasize some of those. For example, there is a sequence of approaching the glaucoma patient. Very often in busy clinics, the patient's already seated when we come into the room. But ideally, we should be able to converse with a little time, because the key to good glaucoma management is diagnosis. The primary glaucomas you will be able to diagnose by your examination, but the secondary glaucomas, you need to talk to the patient. So it's a good idea that you converse a little bit. And if you saw one of the histories about laser PI, where I said that that lady just had headaches and she came in, she denied a history of glaucoma in the family. Had that been there, the gonioscopy would have been done readily by many of us. But most of us would not do a gonioscopy for a patient who just came in as a routine headache. So the message here would be that history taking needs to be done at several levels. Patients will initially deny it. For example, if your optometrist is working up, can document no family history of glaucoma, and you could, while examining the patient, just make a statement, oh, there's no glaucoma in your family, so, and you could move on. But that repetition will actually help. The same thing applies when it comes to systemic disease. For example, asthma. Many of them will deny having asthma, though they are on treatment. And years down the line, they'll say, oh, yes, I've been on treatment for glaucoma for so many years. And then you go back and look at your notes, and that was something you took for granted. One question, and let's start with the intraocular pressure part. I'm very glad nobody's talked about the Schiot's tonometer after a very long time over here. Now, the focus for instrument of choice for everyone is a Goldman applanation tonometer, and two speakers showed that the normal range of pressure was 11 to 21. Now, here's my question. Now, 11 to 21 was described by Leydecke using the Schiot's tonometer. Why are you interpolating that data to Goldman applanation tonometry? So I'll, instead of asking everyone, I'll just put snapshot questions. We also have Dr. Mani Bhaskaran, who's done the Singapore study. So Ronnie, this question is to you. Why do we interpolate this data?
Yeah, so essentially, even though the data came from Schiot's tonometry, the information for normative data from our population comes from population-based studies, where we have examined a large number of normal people who have had normal normal fields. You look at what the intraocular pressure is in those eyes, and you take the mean plus or minus 2 standard deviations. And from the Chennai glaucoma study, which examined about 7,800 patients, we know that that normal range is approximately 10 to 21. It's a little higher in urban population where it's about 22, but that's a range. So most population-based studies, except for the ones in Japan, have, even with applanation tonometry, have come to the same range now.
So it would be fair to say that what Leydecke found with his Schiot's tonometer, we can apply the same criteria with Goldman applanation tonometry.
Yes, this is just one caveat, that the lower level doesn't really matter.
The lower level. So again, the lower level matters, because I can't diagnose normotension glaucoma and go in for fancy investigations if that concept is not there.
That's only the upper level, the lower.
Corneal thickness. How often would you measure corneal thickness? That's the first question. Dr. Mayuri, if you can just take this question.
When I see the patient for the first time of glaucoma, I always ask for the corneal thickness before I start examining the patient.
Okay, so
when I suspect the glaucoma.
So first interaction with the patient, mandatory to get a corneal thickness done. Dr. Preeti, is that the same?
Yes, for all glaucoma patients, yes, central corneal thickness. However, one thing is there is no conversion normogram.
So I'm coming to that. I'm coming to that. So one thing is, are Indian corneas thinner than the average corneas that the Goldman applanation tonometer was described for? I say this because there was a newspaper report which said Indian eyes are thinner and not suited for LASIK.
Yeah, that wasn't from us, but
it was from here.
Yeah,
Delhi.
But if you actually look at Indian corneas, the average thickness of at least the South Indian urban cornea is about 520 microns. But a South Indian rural cornea is about 500 microns. So we are a little thinner than what has been reported in a Western population. But this 20 microns probably doesn't make a huge difference. And Western corneas are the average thickness in most studies is actually closer to 550, not even 520. So 520 is more or less close to Goldman territory. 500 is a little bit on the lower side, but it's not a huge issue.
We also had something 515 was our average.
Yes.
So I understand that the Goldman application tonometer was made for Indian eyes.
Yes, absolutely.
So now here's the question. You have a cornea which is 600 microns. You have a cornea which is 500 microns, two different patients. Are you going to make some adjustments in your IOP measurement for these patients?
No.
No. Anybody else who will?
Basically, actually, the corneal thickness values are more important for those with the suspects than with the established glaucomas.
Okay.
So we use more of this to say sometimes we have a confusion of to treat or not to treat. The corneal thickness, if it is higher, the possibility of progression to the next stage may be a possibility. But when it is really too thin, the chances may be a little higher than those with the higher thickness values.
So
But
this
in
is
established glaucomas, corneal thickness values doesn't matter. Maybe it helps us in sometimes, maybe these patients may have a slightly higher chance, maybe a higher chance of progression. But
So
otherwise,
corneal thickness as a bearing to say to treat or not to treat.
it is not to treat. It is just when you have a cat on the wall, this may be just an additional tool for you to treat or not to treat.
Or like what William Shakespeare said, to be or not to be. Okay. So here's the next question. What normogram would you use?
Actually, no normal. It is just I just keep in mind that, okay, this cornea is thicker and the chances that this person will have a higher IOP, artifactually higher IOP are more.
Okay.
But even then, having said that, I will still follow up because there were patients in the OAT study where they found the cornea is thick, they did not treat, and even after adjusting whatever mentally, some of them still progressed.
We want to know how did they adjust? What did they adjust?
There was no normogram.
So any
was no
normogram which the
normogram.
how panelists suggest that we can use as a take-home message? I agree with her that there is no accepted normogram.
Normogram, yes.
But then what everybody in every meeting says the cornea is thicker, so you have to make an adjustment. But I'm asking on behalf of all of them, what should I adjust with?
Don't adjust with anything. Mentally have a number, but generally, I mean, this is just rule of thumb. That doesn't mean that you do the calculation on paper. Approximately 20 microns, 1 millimeters. But it's not, it is just a very, very rough rule of thumb. And I really would not, please don't write it down.
No, because there are some softwares which patients use in their clinic and automatically a corrected
Convert.
IOP is given.
Is that acceptable?
No.
So every machine is very happy to give you a corrected IOP, but none of them agree with each other.
Can I?
Yes, please, Mani.
Quick thing is, what I do is when you have a thinner CCT and an established glaucoma patient, I'll treat them aggressively. Make it little more towards the lower teens if there is advanced and moderate glaucomas, because usually we underestimate the IOP and undertreat. So that is the only thing I would think about. Higher CCTs, I may be follow-ups, I may be a little more lax, but still I would be vigilant about. It is more like the pickle in your food. Pickle is essential, but you won't just take the pickle alone, no? So you have to look at everything. The patient's whole investigation should be done.
So you can't make a whole meal out of pickle. So the other thing is corneal thickness is important not just for diagnosis, but also in those patients who are progressing despite the intraocular pressure being in the desirable range. So they may be having thinner corneas, and here would be the issue, the measured IOP is higher than the actual IOP in patients who are progressing. So that's how it would all boil down to be. I think let's just move on. One last question. Would you measure central corneal thickness or peripheral corneal thickness?
Central.
Central corneal. And any preferred instrument of choice, whether it should be ultrasound based or whether it should be an optical pachymeter, would that make a difference to my measurements?
So what happens is when you use an optical pachymeter, most of them include the tear film in the thickness measurements. So your thickness measurements with an optical are usually slightly higher versus a contact.
Yeah, but at the same time, we don't know whether we are measuring the central corneal thickness in ultrasound pachymetry also. Because there's a huge variance when we did that. Only when you do the optical, by the visual axis when we measure, the measurements are only about 1 to 2 micron variance. But when we measured with the ultrasound, the variance goes up to 120 microns. It depends upon the staff, the tilt angle, where the patient is fixing. It is a huge variance in the ultrasound packing.
Having said that, we actually repeated pachymetry measurements at 5-year intervals in about 4,000 of our glaucoma, of our study patients, and the typical variance was, I think, under 6 microns.
So if you keep in mind that when you look at a concept like precision for IOP measurement, and you say the intra-observer variability for Goldman apprenation tonometer is about 2.5 millimeters of mercury, isn't that going to take care of small fluctuations or changes in corneal thickness like that?
Absolutely. So even if you look at repeat testing, the variation is not high. It's not really enough to impact your interpretation and of its impact on IOP.
So go back and look at the current definition of glaucoma. It does not use the word intraocular pressure. You don't need to have high intraocular pressures. And still you measure intraocular pressure because you're using it as a surrogate marker to assess the response to treatment. So keep that in mind. Let's move on. Optic disc evaluation. Mandatory for all patients at the first visit?
Absolutely, yes.
Absolutely. And instrument of choice. So how many of you would see the patient at the first visit, undilated, you've seen with the 98D? Would you prefer a 98 or a 78 or a 60 diopter lens as a first choice?
Whichever you are used to. I'm used to 90D.
Yeah, so I want to hear what you are using.
I'm using 90D.
Anybody else who's differing from the 90D lens?
90 is fine, but 78 may be a little better for glaucoma.
Okay, but undilated 90 would be better.
Yeah,
78 would work very well with a dilated pupil. So one thing is, every time you see an optic disc, and here's my suggestion, and you can comment, when you see a disc and you're thinking in terms of glaucoma, seeing the disc, you should be able to say what kind of visual field changes you would expect if this is a glaucoma disc. The same thing will apply when you see a visual field in isolation. When you see a visual fields, you should mentally be able to picturize what kind of an optic disc change you would expect if you're thinking in terms of glaucoma. Now, this becomes very important because when you see an optic disc, you should be able to say, does it match with the visual field changes? And if you see a visual field and then see the optic disc, you say, my visual fields corroborate or correlate with my optic disc changes. Again, the other aspect is that why do we do visual fields? Because visual fields are no longer in the definition for glaucoma. So are we making our patients waste money by doing visual fields? Preeti?
Actually, even intraocular pressure is not in the definition of glaucoma.
But still we measure.
Yeah, exactly. So glaucoma is a disease where IOP, perimetry is not in the definition, but we are treating patients and monitoring patients based on IOP and perimetry. Perimetry remains the only functional test, and we are interested in function. My little finger might be crooked, but if it's able to hold weight, I'm able to write properly, that's what I want to do. So that's how it is. So perimetry remains the functional test, and I don't think it's going away ever.
But they've removed it from the definition, actually.
Absolutely.
It's
It
in
is
the
not in
process
the
of going away.
definition. So that's pre-perimetric glaucoma. So disc evaluation, the disc is the story of glaucoma, but however, perimetry and intraocular pressure are so important.
How many of you find this concept very confusing? Perimetric glaucoma, pre-perimetric glaucoma, structural change? Yes or no? So let's do away with the perimeter. There's no pre-perimetric glaucoma. There's always glaucoma. There's always a nice red color on the OCT printout, and you can start treatment with. No. I'm coming to emphasize that. But, you know, again, we showed you examples where the fields were showing a change, but actually there was no glaucoma. The reverse will also hold true. Your OCT will show a change because in a very simplistic manner, normal has to be predefined statistically for the OCT to function. So if, say, the optic disc size has been described as X, and you see an optic disc larger than that, all measurements are going to change on the OCT. And therefore, when they do the statistical comparison, there's going to be a mismatch and you're going to have red color. Another simple example. The average height is, say, 4 to 6 feet. But if you see a 6.5 feet person, his arm spans or all body parameters are going to be different. And therefore, he will appear to be abnormal while actually he can be normal. So keep this example in mind. Similarly, the same will apply to a person whose height is less than what you would expect for normal. Just because height is the criteria, he may appear to be, but that doesn't make him abnormal. how do you respond when a patient comes to you having got an OCT on, say, X machine, and now he has gone and shown a second place and on a X to a different brand of machine, and he's come to you now asking, I was diagnosed to have progression over there. How do you tackle this patient?
Is that progression or glaucoma?
The
Okay.
OCT, the progression has been defined by the second OCT, which was done on a different brand machine.
Yeah, so you just can't. You cannot compare two machines. What they measure is different. A thickness here is not equivalent to a thickness on another machine. And even on the same machine, unless you have registered the first measurement, the second measurement is not comparable to the first measurement. Unless you have overlapped the exact circle of measurement.
So is there a consensus on this?
Even if it is the same machine, same place, just with the OCT alone, I'm not going to say it is progression.
Why? They're doing so many studies and spending money and having so many meetings where they say progression is based on OCT, and
Unless it is corroborated with your functional change and whether it is going to be useful progression, that is to be stopped by for that particular
but
patient.
doctor, you're investing money and buying such an expensive equipment to assess progression, and if you're buying and using this for your patient repeatedly and not actually using, just imagine how heartbroken the patient would
Not
be.
actually using, I know where you're coming to, but I would like to give the proper thing to the audience. Basically,
Achha, tell me, am I
you
wrong
need
in putting this question? So they're supporting me actually.
as long as we are having a functional change registered or a difference in the two corroborated with other findings, you need to, because it's a syndromic thing. You can't just depend on just one investigation and make a treatment there.
So here's, I'm willing to do more investigations as long as the patient is paying. So here's my question. Okay, we'll come to that part again. But again, you know, the question is very interesting. For many of us, we use the word progression very casually in our clinics. I've said this earlier also. From a patient's perspective, progression is disastrous when the doctor uses this word. He thinks, I've been coming to this doctor repeatedly for so many visits or years, and now he's talking about progression. He has actually not treated me well, and my disease is progressing. I need to sue him. This is a thought which runs through our mind. So when we come to meetings and we talk about progressions and the way we put it across, if we put it the same way across, patients are going to get dissatisfied with what we are doing. So this is something that we need to keep in mind. So there was a question coming from the lady in the back. Would you please speak loudly and tell us?
It was regarding the case studies. We've got a routine when a 50-year-old lady presented for presbyopia correction. What was the indication of doing gonioscopy in that patient? And plus, what is the treatment protocol or rather course of action post YAG PI?
Well, that's a very interesting question. Let me rephrase this. Can angle closure, is the presentation, what is the classical presentation for angle closure? Bhaskar, let's put this to you, because in Singapore you have had a snapshot of different populations. How would angle closure present typically? Not the textbook headache, colored circles on bright light. Not acute angle closure. So a typical angle closure, can you just listen to the patient's symptoms and say this is angle closure? No. Anybody from the panel, other panelists?
The huge majority is asymptomatic.
Sometimes they can complain of frequent headaches, off and on, changes of the presbyopic correction.
Changes in press
Frequent
back. So
changes.
headache is not uncommon. In fact, there's a study from RP Center where they have looked at the classical presentation of angle closure as described in the textbook with what they have been seeing in their clinics. And they said the classical features are usually absent, and angle closure mimics open angle glaucoma unless and until you look for the shallow chamber or you're doing a gonioscopy. Dr. Murli, you wanted to add something?
Yeah, I just wanted to, while the discussion is on angle closure, and we all use technology for, besides gonioscopy. So we'll probably discuss the role of the new gadgets in screening for angle closure. I think it's a huge problem, at least I face, and all patients coming to us with different images from different machines, saying angle is 12 degrees, angle is 18 degrees, angle is 34 degrees, and so on. So the role of AIOS2025 and these devices, while you're talking about expensive OCTs, I think you talk about OCT for the angle as well, whether it's relevant in our practice, whether gonioscopy still remains the gold standard.
So the problem with gonioscopy is that it's not expensive, and therefore we find it very difficult to realize its value and communicate this to our patients. But had this cost 30 lakhs, we would have been very aggressive in doing gonioscopy and getting the maximum out for our patients. But we are not wanting to gonioscopy and go on to a fancy gadgets like anterior segment OCT and UBM because they are more expensive. And when you do something with an expensive instruments, patients are actually more satisfied. But let's hear it from them also.
I think it's got absolutely no role in screening or diagnosing.
Gonioscopy or anterior segment OCT?
Anterior segment OCT.
imaging.
That's very interesting actually, because in your clinics you do more cataracts, you want to buy more equipment, and one of the first things you think of is an anterior segment OCT as a substitute for your gonioscope.
So we have
Has one gonioscopy equipment separately. Regular gonio.
How much does it cost?
Around 20 plus.
What?
Regular gonio.
So he speaks only in lakhs.
See, now you will value this gonioscope much more. So I'll come back. How often should gonioscopy be done for a patient who's been following up with you regularly? At diagnosis, we are all aware about it. Dr. Murli, you have a talk. Can you please come and load? Yeah, okay. So, Ronnie?
So our protocol is definitely at first visit, and then after that annually, or if you see any change, if you see a pressure that is going up, if you see progression that's happening and you can't explain it, always better to do a gonioscopy, because sometimes that's all that's happening. An angle that you've been treating as open can close with age.
Okay. So another aspect that comes out, and this would apply both to the tonometry and gonioscope. How do you disinfect gonioscopes and tonometers? What's the practice in your clinic?
I'm using applanation tonometry.
So how do you disinfect?
Oh, clean. I use alcohol swabs.
The regular alcohol or?
The swabs are available.
The alcohol.
Alcohol
So
swabs
75%
are available.
isopropyl alcohol.
80% alcohol.
Ronnie, same thing?
Glutadriate wipes.
Glutaraldehyde, these are available?
No, we use a spray. We
Okay. So spray is commercially available? I was not aware about it.
you can put in a bottle. That's all.
Anybody else doing something different?
So what we do at the beginning of the session, the first patient of the session, before that we disinfect with this disinfection with the alcohol wipe which she mentioned. And subsequently between patients, we don't use an alcohol wipe for every patient. We use a disinfectant wipe with a sterile wipe. Just wipe it mechanically clean and then follow up with every patient. And only once in the morning, in the beginning of the day, we start with that. And suppose we know a known infected patient or a known patient with an infection, then we again use a disinfectant. Otherwise, we don't use alcohol for every patient. But sometimes the alcohol gets left behind. We sometimes contact the cornea with the alcohol. So that's a worry. And we have no issues with just the disinfectant sterile wipe.
How many of you use water wash? Tap water.
So actually, none of you should be hesitant in saying yes, because that's the best way of doing it.
I use it.
Yeah, that's the best way of doing it. The key is to have a mechanical wipe, because Creutzfeldt Jakob disease, some protein elements get deposited on the
mechanical
tip.
wipe is the key.
Is the key actually. So a good wash under running water, simple soap, and drying is very important. The key is drying. If you can't do anything, dry. If you can do something more, running water. And fancy clinic?
That is what I am really surprised. Nobody is saying that they are not
Wiping
using
it
water.
Yeah, so I think, the mindsets have become such that we are wanting to move more technology-based, and therefore things are getting left out. So any other questions from the house? Yes, ma'am, please.
So next course of action post YAG PI in the first
So,
patient.
okay, so let me just rephrase this. You've done the laser PI today. When will you see this patient next? So, okay, here's something which is very important. Your follow-up criteria will depend on the kind of practice you are in. Are you an individual or are you in an institutional-based practice? So let me just categorize here and put Dr. Ronnie and Dr. Satyan and Dr. Preeti as three components, because they're in different roles. Dr. Preeti is in a more individual-based practice. Satyan comes from a group practice and institution-based, and Dr. Ronnie also comes from an institution-based. Dr. Mayuri has just transitioned from an institution-based to a semi-individual-based. So just give me quickly what criteria you would follow, how frequently you would see this patient.
So I haven't changed what I was doing it at Arvind. So do the laser, because what we are talking about is a PACS I'm talking about, okay? Do the laser and immediately we see them, and then I do follow up only at the end of 10th day. When the tapering is done, everything is done, I see them on the 10th day.
Okay. Dr. Divya?
That is the first.
That's the first. Okay, PS. So, Dr. Divya, what would be your criteria for follow-up?
After a laser PI, I would like to follow my patient after a week. And also do a gonioscopy to see if it is open or not.
So, when we say we'll follow up, it's very easy for us to say follow-up. What exactly will you do when they come back for the follow-up, other than the routine vision and intraocular?
Yeah, a gonioscopy would be done.
So, gonioscopy at the first visit, 1 week. Is there a consensus on that amongst everybody? Yes. Anybody differing from this?
No, I would definitely do the gonioscopy at the next visit. I would usually call them maybe 2 to 3 weeks, because sometimes by that time whatever pigment dispersion related or steroid related issues have settled down. But a gonioscopy is mandatory at the next visit, and a dilated fundus exam if you haven't done it yet.
And in angle closure after dilation also check the eye. Sometimes even after the PI the angles can close and the pressure can go high after despite the pain. Okay. So those patients have to be followed up more closely. That's why. So dilated IOP is also what.
So here's my question. What is the aim of the laser iridotomy? Is it to lower the intraocular pressure? Is it to make sure that the angle opens up? Or is it to make sure that the angle doesn't close any further?
It's the pupillary block mechanism. We are addressing the pupillary block mechanism, not to lower the intraocular pressure.
Sorry, I didn't.
Pupillary block mechanism.
Pupillary block mechanism. But is it going to... So many people say, I got the laser done, my pressure has not come down. Has the procedure failed?
It depends on how much is your angle closure preferred and the plateau iris.
So here's the other part of the question. Why do we do a gonioscopy post-laser? Anyone? Why do we do gonioscopy post-laser?
So not all angles are going to open up post-laser iridotomy. Data from India suggests that about 75% of angles will open. 25% will continue to have some degree of apposition closure. Most of them are going to be plateau iris, and they require much closer follow-up, and they are more likely to progress than an angle which is completely open.
Okay. So angle closure is not just about a pupillary block to relieve the laser iridotomy. The non-pupillary mechanisms can be identified only after the laser has been done. Now, as a consensus, we have discussed how you will make the glaucoma